Hello everyone. Uh, Today we'll continue talking about gout and hyperuricemia, and it will be particularly on treatment parts and most important or integral part of pharmacotherapy or therapeutics. Acute gouty arthritis. Uh, Acute gouty arthritis is actually can be relieved with the first line medications, and if it's chronic or it's not responding to the first line treatment, another medication are used. So the treatment of acute gouty arthritis are may be non-pharmacologic therapy without using of medications, maybe lifestyle modification, etc., and pharmacological therapy. So let's start with the non-pharmacologic therapy. What can we do to relieve acute gouty arthritis without medications or drugs? First, reduce the intake of foods high in purines. Food high in purines or genetically modified as organ meats. Number 2, avoid alcohol. 3, increase fluid intake. Lose weight of obese. Joint rest for 1 to 2 days. And local application of ice may be beneficial, may reduce the or relieve the inflammatory signs and symptoms as redness, pain, swelling, etc. Smoke. Strong actually. We'll start with the pharmacological part now of treatment, and the first or the major therapy is non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. As we know that gout is an inflammatory disease. As we know that when extravasation of leukocytes happen and leukocytes exit from the blood vessels to the site of inflammation, which is the joint, and crystals appear, and etc. That what we discussed before in the previous parts of gout. So as we said, NSI, I'm sorry, it has a abbreviation, non-steroidal anti-inflammatory drug, NSA, the drugs. Non-steroidal anti-inflammatory drugs, that's its NSAIDs, are the mainstay of therapy because of their excellent efficacy and minimal toxicity with short term. So why are NSAIDs are ministry of therapy, or why they are the major of therapy? Because of three things: efficacy, minimal toxicity, with short term, and short term may reduce the adverse effects. And actually there is a little evidence to support non-steroidal anti-inflammatory drugs. as more efficacious than another, and 3 drugs. It's actually have been approved by the FDA, Food and Drug Authority, that there are 3 efficacious drugs than another, which are like indomethacin, naproxen, and salimidac. These 3 drugs have been approved by the FDA about being more efficacious than other. Therapy should be initiated with maximum recommended dose for a gout. With the maximum recommended doses for a gout, there is a dosage regimen especially designed for gout and hyperuricemia. So we should start the therapy with the maximum recommended doses. At the onset of symptoms, and we should continue the therapy for 24 hours after complete resolution of an acute attack, then tapered or decreased quickly over 2 to 3 days. So first, you have to start or initiate therapy with the maximum recommended dose for 20 hours. After 20 hours or after the symptoms of an acute attack has been relieved, you need to reduce or taper it quickly over 2 to 3 days. Once the symptoms are relieved within 24 hours, you need to taper it quickly over 2 to 3 days. Acute attacks generally resolve within 5 to 8 days after initiating therapy. So, the acute attacks generally resolve or relieve or cured within 5 to 8 days, like about 1 week and a day after initiating the therapy. Here's the generic names of some non-steroidal anti-inflammatory drugs, and here are the dosage regimens of non-steroidal anti-inflammatory drugs for treatment of acute gouty arthritis. These regimens are designed for treatment of acute arthritis. So we have etodolac, and etodolac, the dosage and frequency, actually it's not easy to memorize the dosage and frequency. So with the practice and with the recurrent reads or use, they may be a staple in your brain. So 300 milligram twice daily. This is for etodolac. For phenylprofen, it is 300 to 600 milligram 3 to 4 times daily. 3 to 4 times daily. 300 to 600 milligram. And we have ibuprofen, which is the most common used on non-steroidal anti-inflammatory. 800 milligram 4 times a day. 800 milligram 4 times a day. Indomethacin is one of the FDA approved medication that is more efficacious than other drugs, and the dose is 25 to 50 milligram 4 times a day for 3 days, then taper to twice daily for 4 to 7 days. So first is given as 25 to 50 milligram QID or 4 times a day for 3 days. After 3 days, this dose should be tapered the same strength, 25 to 50 milligram, but instead of taking it 4 times a day, it is tapered to twice daily for 4 to 7 days. ketoprofen 75 milligram 4 times a day, naproxen, and it's one as the FDA approved drug, 500 milligram twice daily for 3 days, then 250 to 500 milligram daily for 4 to 7 days. So as we can see that the dosage regimens for indomethacin and naproxen are way similar, that the dose is tapered from twice daily for 3 days, then to 500 milligram daily or once for 4 to 7 days. And piroxicam 20 milligram once daily or 10 milligram twice daily is the same. You can take the dose as a whole, or you can space doses. Salindac 200 milligram twice daily for 7 to 10 days. These are actually the dosage regimens, and these tables actually are really important. I'm thinking of printing these tables and reorganize them in small or in a hand booklet, so I can take it with me anywhere while practicing it. Adverse effects. Adverse effects are actually more common with long-term usage. The most common adverse effects for non-steroidal anti-inflammatory drugs are in the GI system, in the gastrointestinal system: gastritis, inflammation of the stomach, bleeding, and perforation. So GI system adverse effects that maybe happen from NSAIDs are gastritis, bleeding, and perforation. Kidneys, renal papillary necrosis, and renal papillary necrosis or renal insufficiency, or it may also be termed to acute renal failure. It can result from the therapy. What is actually renal papillary necrosis? Renal papillary necrosis, actually, it is a coagulation of the medulla and the papilla in the kidney, and that may lead to renal insufficiency. And actually, I searched about the renal disorder. As we can see here, causes of papillary necrosis, they are actually abbreviated to postcards. P for pyelonephritis, O for obstruction of the urogenital tract, S sickle cell disease, hematology, and tuberculosis. And postcards, C like chronic liver diabetes, A, which is analgesia, because as we know that non-steroidal anti-inflammatory are analgesic group of analgesic drugs, so analgesia may cause papillary necrosis. So it's one of the causes of papillary necrosis, the analgesia. Renal transplant rejection, diabetes, and systemic vasculitis. So we have discussed the adverse effects relating to gastrointestinal system and kidney kidneys. We have discussed about renal papillary necrosis, and it may lead to reduced or decreased creatinine clearance. Clearance of creatinine. As we know, creatinine is a toxic substance that actually is excreted in urine. So if creatinine is not cleared from the blood, it may lead to adverse or toxic effects, as we know. Cardiovascular system, it is very important, and people with hypertension, it may lead to sodium and fluid retention, increase the blood pressure. So these things should be concerned when taking non-steroidal anti-inflammatory drugs. Central nervous system, like impaired cognitive function, headache, dizziness. So, yeah. Safety and contraindications and drug interactions. It's the most important part. Although the risk of gastrointestinal complications is relatively small with a short term, it is small GI complications, relatively small with short-term therapy. Q administration is like administering the drug with another drug, with a proton pump inhibitor. As we know, the proton pump inhibitors are drugs used to relieve gastric acidity, so they decrease the hyperacidity of the stomach. Should be considered in elderly patients and the others at increased GI risk. So if we administered or co-administered non-steroidal anti-inflammatory drug with a proton pump inhibitor, as we know that one of the GI complications or adverse effects of non-steroidal anti-inflammatory drugs is gastritis, hyperacidity. So proton pump inhibitors decrease the acidity, and non-steroidal anti-inflammatory drugs increase the acidity. So that's an antagonism reaction. This is a drug interaction. Non-steroidal anti-inflammatory drugs should be used with caution in individuals with a history of peptic ulcer disease, as we know, peptic ulcer or hyperacidity, heart failure, uncontrolled hypertension, as we've discussed, because one of the adverse effects to the cardiovascular system is hypertension, renal insufficiency, as we know that renal papillary necrosis, coronary artery disease, or if they are receiving anticoagulants concurrently. If the patient is receiving anticoagulants, should be used. This drug should be used with caution for this group of diseases. Okay. The second drug in first-line therapy for acute gouty arthritis, we're still in the first-line therapy. Colchicine. Colchicine is an antimitotic drug that is highly effective in relieving acute gout attacks, but has a low benefit toxicity ratio than the non-steroidal anti-inflammatory drugs. So it may be toxic, but it has a low benefit toxicity ratio. It means that non-steroidal anti-inflammatory drugs are less toxic than colchicine. So it's highly effective. But when is highly effective? When colchicine is started within the first 24 hours of an acute attack, about 2/3 of patients respond within several hours. When the therapy or the dose is given to the patient within the first 24 hours of an acute attack, the attack is already processing. 2/3 of patients respond several hours. The likelihood of success decrease. It is highly effective, as it's mentioned before, but this efficacy may decreases substantially if a treatment is delayed longer than 48 hours after symptoms onset. So, if the treatment is delayed or it's given in a lately longer than or more than 48 hours, 2 days after symptoms onset, so it should be given at the start or at the onset of symptoms, so it can have the effective in relieving. Oral colchicine causes dose-dependent GI adverse effects. It is dose-dependent, so if you had a higher dose or overdose, it may lead to GI adverse effects like nausea, vomiting, diarrhea. In 50% to 80%, and it's important percentage, relatively high percentage of patients before relief of the attack. Before relief or at the onset of initiating or starting the therapy, patients experience GI adverse effects, nausea, vomiting, diarrhea, 50% to 80%, relatively high percent. That's for the GI adverse effects. Here we are talking now about the adverse effects of colchicine. Non-GI adverse, non-gastrointestinal adverse effects include neutropenia. And neutropenia, actually, it is an immune disorder, and it's low number of neutrophils, and neutrophils is one of the white blood cells that are responsible for the immunity. So if they are decreased, infections, bacterial infections, and viral infections may happen and may lead to adverse effects. And axonal neuromyopathy. Axonal neuropathy, or it's called Guillain-Barré disease. It's a central nervous system disorder. It is associated with the loss of motor or paralysis for motor nerves, and but without a loss of a sensation. So that's the axonal or Guillain-Barré syndrome, which may be worse in patients taking other myopathic drugs. So if a patient is taking colchicine and he is suffering from Guillain-Barré syndrome, and this may be worse even with taking other myopathic drugs like statins, or in those with renal insufficiency. So here we talk about the kidney renal insufficiency may have adverse effects in taking colchicine. People with neutropenia and axonal neuromyopathy. Colchicine shouldn't be used concurrently with macrolide antibiotics, especially clarithromycin. So it should be, for safety reasons, should not be used macrolide antibiotics as clarithromycin. The dosage. The usual oral colchicine dose is 1 mg initially at first, followed by 0.5 mg every 1 hour until the joint symptoms subside. So at first, the dosage of colchicine is 1 mg. After that, it is reduced to 0.5 mg every 1 hour or Q1 hour until the joint symptoms subside. The patient develops abdominal discomfort or diarrhea, or of a total dose of 8 mg has been given. So the dose should not be exceed 7 mg, because if it's 8 mg Adverse effects may occur as diarrhea, discomfort, abdominal discomfort. So as we said, the gastrointestinal adverse effects are dose dependent. Okay. IV colchicine should be avoided. IV intravenous colchicine should be avoided because it is associated with serious adverse effects. So giving colchicine intravenously is or should be avoided. Why? Because bone marrow suppression, and we know that bone marrow suppression may lead to anemia, may lead to low blood counts, tissue necrosis, intravascular coagulation, because bone marrow produces the blood or blood cells, and hepatocellular toxicity, kidney and renal failure. So it's really given it is risky and should be avoided. But if considered necessary, or if the patient is unconscious or cannot swallow the pill or cannot take the medication orally, for example, etc., the recommended initial IV dose, the first IV dose is 2 milligram. If renal function is normal. If renal function is normal, the first IV dose is 2 milligram. This 2 milligram actually is not given as 2 milligram. It is diluted to in 10 to 20 milliliter of normal saline solution, and the 2 milligram may be a powder or may be diluted into 10 to 20 milliliter of normal saline, administered slowly over 10 to 20 minutes. So administering the first dose slowly over 10 to 20 minutes in a secure free-flowing IV line, to avoid extravasation. Extravasation actually is the leakage of a fluid to the extracellular space, and it's really correlated with adverse effects, and inflammation may happen from extravasation. This may be followed by 2 additional doses of 1 milligram each. After the first dose may be followed as necessary by 2 additional doses of 1 milligram each at 6-hour intervals, like Q6 hours, every 6 hours, with a total dose not exceeding 4 milligram. So if it's up to 4 milligrams, that's not a good choice. After a full IV course, and that's an important point, patients should not receive colchicine by any route, orally, IV, or any, for at least 7 days. So they should stop receiving colchicine after they have had a full IV course. They should not receive colchicine by any route at least 7 days. Okay, now we'll be moving to the second line treatment, and it's corticosteroids. Corticosteroids primarily for patients with a contraindication or who are unresponsive to non-steroidal anti-inflammatory drugs or colchicine therapy. So corticosteroids actually are given at the last when the patients are unresponsive to prophene or colchicine therapy. Patients with multiple joint involvement may also benefit. So as we know that Gouts may at first be monoarticular and then multiple joints, started at the metatarsal phalange and then knees, wrists, tendons. So multiple joints also may be beneficial. The drug, which is prednisone 30 to 60 milligram or an equivalent dose of another corticosteroid, an equivalent or the same dose of another corticosteroid other than prednisone, orally once daily for 3 to 5 days. This is the dose, frequency, duration. Prednisone 30 to 60 milligram orally by mouth once daily for 3 to 5 days. Because rebound attacks may occur upon steroid withdrawal, so it has withdrawal adverse effects. Corticosteroids have withdrawal adverse effects. The dose should be gradually tapered or decreased in 5 milligram increments over 10 to 14 days and discontinued. The dose should be tapered in 5 milligram increments over 10 to 14 days and then discontinue. You shouldn't, or the patient should not discontinue corticosteroids immediately after the symptoms relieved. A single intramuscular injection of a long-acting corticosteroid as methylprednisolone acetate, can be used as an alternative to the oral route if the patients are unable to take oral therapy, if they are unconscious, if they are elderly, if they are children and cannot swallow the pill or cannot take the medication therapy. Only a single intramuscular injection of long-acting corticosteroid can be administered. Alright. Intra-articular is like into the joint. Administration of triamcinolone hexastenoids 20 to 40 milligram may be useful for acute gout, limited to 1 or 2 joints. Also, another intraocular administration of triamcinolone 20 to 40 milligram may be useful for acute gout, limited to 2 joints, also for multiple joints, or for patients who are unresponsive to NSAIDs. Okay, adrenocorticotropic hormone. This is a hormone gel. It is gel. 40 to 80 United States pharmacopoeias may be given intramuscularly every 6 to 8 hours for 2 to 3 days. May be given, but studies shown with adrenocorticotropic hormone are limited, and it should be reserved, or it should be given with caution for patients with contraindications to first-line therapies as heart failure. Now move to prophylactic therapy of intercritical gout. For example, if you measure the uric acid concentration in the blood and it was above 7 milligram per deciliter and you are at risk for having gout or hyperuricemia, you need to, or you will probably take a prophylactic, or the physician will prescribe you prophylactic therapy. Colchicine may be used as a prophylactic, and it's actually really long contraindications and explanation, so I actually said refer to textbook page 7. Uric acid lowering therapy and xanthine oxidase inhibitor, and you know that xanthine oxidase inhibitor, it is I remember that we studied about a pathway in biochemistry, and xanthine oxidase inhibitor, which is called allopurinol, is allopurinol inhibits xanthine oxidase, which and xanthine oxidase actually will this is an enzyme, and this enzyme actually will lead to a pathway, and the pathway will end with increase in uric acid in the blood. Uricosuric drugs as propenicid and sulfonylurea, propenicid and sulfonylurea. These are some drugs that are used in prophylactic therapy. Evaluation of therapeutic outcomes is important as clinician pharmacists. A serum uric acid level should be checked in patients suspected of having an acute gout attack, people or patients at risk, or they are suspected of having an acute gout attack, particularly if it's not the first attack and a decision is to be made about starting a prophylactic therapy. If this is, or if it was not the first attack, and the decision is to be made about starting a prophylactic therapy, the serum uric acid level should be checked. Patients with acute gout should be monitored for symptomatic relief of joint pain as well as potential adverse effects and drug interactions related to drug therapy. So patients who are actually gout with hyperuricemia should be monitored for symptomatic relief of joint pain as well as potential adverse effect if they have an adverse effect. These are all should be monitored in the drug interactions related to drug therapy. Patients are receiving hyperuricemic medications as nitrile, as the medications that we discussed, should have baseline assessment of renal function, hepatic enzymes, complete blood count, and electrolytes should be monitored or assessed. Because of comorbidity with diabetes, dyslipidemia, hypertension, and stroke, the presence of increased serum uric acid levels or gout should prompt evaluation for cardiovascular disease and the need for appropriate risk reduction measures. Clinicians should also look for possible correctable causes of hyperuricemia, medications, obesity, alcohol abuse. Thank you for listening, and if you have any questions, you can ask me, and I will be happy to answer your questions. Thank you.